Welcome to this panel discussion at EACTS in Vienna. My name's Joel Dunning, and I'm a VATS thoracic and cardiac surgeon from Middlesbrough. And I'm here with two surgeons, and we're going to talk about VATS Lobectomy, but we're also going to talk about a few other things that don't come up so often, and talk about perhaps thymectomy. I'm joined by Payman Sadari-Nia. He's a surgeon from Maastricht. You've also been on EACTS Council as trainee representative. And last year you presented a critical appraisal on VATS Lobectomy and the evidence for it. And I'm also joined by Marco Scacchi. You're a consultant in Papworth Hospital. And as well as doing a lot of VATS lobectomies, you also have my favorite YouTube video on single port thymectomy. So perhaps first of all, I think we'll just start off by describing our own technique for VATS lobectomy and then maybe have a little talk about what we think why it is so good. So from my own point of view, I'm a trainee of Bill Walker's, so I stand on the wrong side of the patient, some people say, but the posterior approach, which is Fisher-based. I use 3 ports, I use a 5mm camera and an anterior incision. I think posterior approach is just great for segmental resections. I love it for that. But if it had to have a disadvantage, it would probably be when there's an incomplete fissure. So, welcome, Marco. I guess you stand the other side, do you?
I do. Well, my preference, as you said, is to stay in the front of the patient and I dissect the structure as I see them. I find it, this approach is quite easy. You have good control of everything, and the main difference from usual is that I hardly go into the fissure unless it's complete and it's that easy to dissect it. I try to spare the fissural dissection because you get a lot of air leak from there and oozing, and the procedure at least in my end, tends to take longer, so I avoid that step.
How many ports do you use?
3 ports.
And do you vary them around much?
No, I think it's always the same position for the port. So I put a camera port in the 7 intercostal space, anterior axillary line with the 30-degree scope that gives me a good view of the hilar structure. Then I have about 4 or 5 centimeter utility incision. It's non-rib spreading. I use a soft tissue spreader, but no rib spreading, and then a posterior port, which is basically along the posterior axillary line, roughly where the lower lobe touches the diaphragm, and that is the port that I use for retraction of the lung and to staple all the hilar structure.
And do you feel any difficulties with that approach? Some people say firing away from yourself a bit, sometimes a bit difficult, or?
No, because actually, if you have a good assistant, but no, even with the 30-degree scope, which I use in every case, I can always see the end of my stapler. I can see exactly where the stapler is going, and I now recently discover one company that produces an angle stapler, which I find it very, very easy to use, especially in narrow space to go around vessel.
Right.
So sometimes I don't even put anymore a vessel loop around or a suture around. I just use the angle of the staple.
Yep. So we're in Britain. We don't have as much money as him. I wonder if you'd like to tell us your approach. I hear you're slightly robotic.
Yes, at our center we do a lot of robotic lobectomies and thymectomies, but I have to say I was trained in VATS lobectomy in St. Antonius, and the approach that I have always used is a subxiphoidal approach, and the concept is that you want to avoid an utilization thoracotomy, and you want to have a totally closed checked chest operation. So in that kind of surgery, you have the patient lying on the back in a supine position. You have a retractor that goes at the subxiphoidal level to retract the lung, and you have 3 ports, incision, and the thoracic side. The advantage is that you can take this the specimen through the subxiphoidal approach. You can put the drain there, so no drain between the ribs, etc. But now we have are doing a lot of robotic lobectomies, and the reason is it is easier with the robot, and the robot is it gives you also more comfort and ability to train the young surgeons, because we have a training program in which our trainees are trained for cardiac and thoracic, and they have to do a certain operations in thoracic. And if you do all these operations for which you have a steep learning curve, then it is not so easy to train them. So I think my personal opinion about all these approaches is that the main thing, it has to be a total oncological resection with a systematic lymph node dissection. If you can do it anterior approach, posterior approach, or with robot, that is the end issue, and that is something that has to be done. And I think we all are trained differently, and eventually what is important, which technique is more comfortable for you.
Yeah, I mean, robots are never quicker, are they?
No, of course, they are more costly. It is it takes time in the beginning for the setting up the robot, but
Let's talk
I think
a bit,
it is different.
Yeah, let's talk a little bit more about this interesting subxiphoid approach. I mean, we just talked about it outside of this room, but I'd never actually even heard of this approach. I mean, how widespread is it, and is it something people should try?
I think you should. The first thing is that you should try it and see. It is much easier for your lymph node dissections, but also the dissection of fissure. It is in front of you. The lobe is retracted away from the fissure, and you can work directly like you do it in open surgery. So, and the most interesting part of it is that you are avoiding an utilization incision. What is important is that you have to, of course, it is patient lies on the back and supine position with the pillow. So you lift the thorax a bit. You have a constant position of the trocars. You have to have your camera position very low, because you want to have a view of the whole thorax. And in my opinion, is as much easy to learn as other techniques.
So maybe if we just change track a little bit, you've done some very interesting work with 3D planning,
Yeah.
and certainly I would absolutely love to know where my pulmonary arteries were before I crashed into them with a large diathermy. So
I think that is a very interesting development, and development that there are many applications with which you can have a conversion of all the data on the CT scan, MRI, every echo to a 3D reconstruction. And then based on that, you can modulate the data that you have, and you can concentrate on the data that you are interested in. For example, you have a CT scan of the patient, you get a 3D reconstruction, and then you can adapt the system that you are only looking at the vascular structures or bronchial structures, and you can use that in your preoperative planning. And I think that is the concept that is all evolving, and the concept of individual treatment of the patient, not only treatment of the disease, the treatment modality that you're using, but also the surgical treatment is tailored as based on the anatomical data that you have in the preoperative fashion, that you can plan your operation. There are also even applications that you can simulate your operation, segmentectomies or even lobectomies beforehand, before that you start.
Yeah, and you were talking about the concept of actually planning different ports for every single different type of segmentectomy. But from my point of view, I quite like them in the same place. But it's a conceptual issue, isn't it? And so maybe if we move on a little bit from that, Marco, what do you think about segmental resections? I suppose I love the posterior approach for these, but what's their role? Someone with good lung function and a stage 1 cancer, I mean, should you do a segmentectomy if you could, or should you just take the lobe out for better survival?
I think at the moment there is some suggestion that for early stage lung cancer, a segmentectomy might be as good as a lobectomy. Nevertheless, I don't think that we have the strength of the data yet to advocate in a good patient with good lung function fit for lobectomy, advocate a lesser resection.
Yeah, I think I agree. And Payman, what's your view on N2 disease? A little station 7 positive on mediastinoscopy. What do you do with these patients? It's otherwise a T1B tumour, but you picked up one station.
I think normally is we decide that in a multidisciplinary fashion, and the consensus is that if you have a preoperative N2 disease, that those patients are referred to induction chemotherapy, and then if you have a downstaging, that they can be operated on. Of course, there is a lot of controversy about the N2 disease. I mean, every N2 disease is not the same. You have bulky N2 disease, you have one-stage N2 disease, you have N2 disease that you have this unexpected N2 disease during the operation. So it is a whole area and differences between all those group of patients, and that comes all to biology.
I mean, David Waller's just written a paper, hasn't he, on he's just compared his intentional N2 patients he took straight to theatre and compared them to intraoperative and found they were the same. What's your policy?
Well, in the UK, we follow BTS guideline and NICE guidelines, so therefore we don't do induction treatment for N2 disease. But I agree with Payman. N2 disease is a spectrum of disease, so you can have a microscopic metastasis in a node which is otherwise normal, or you can have a bulky disease. So of course these are, although they are called N2 disease, but biologically they behave completely differently. So if it is a micro metastasis in N2, I would take the patient straight to theater, and I would perform a systematic nodal dissection with all the stations, all the soft tissues, and of course the patient will get adjuvant treatment.
Yeah. So let's change track a little bit. Thing I like is gadgets. I love gadgets, and I was looking at YouTube and I saw this amazing Sills thymectomy, and it was your video, and I've used the Covidian sort of clinch dissector. It's a fantastic little thing, bends at the end, and it's got a little grasp. It's great. So I wonder if you could tell us a little bit about how you do your thymectomies or your experience with the Sills ports.
Well, I've done a number of 3 ports thymectomy. Normally I do it on the right side, putting 3 ports along the breast crease, and with the CO2 insufflation, and that worked very well for me. And then one day I heard about this Sills port, and I just got a patient referred with a small thymoma, and I thought, maybe it would have been easier to access the tumor straight in front of me. And at the same time, I also had a visit from a representative of a company that has some powered instruments, or basically they are like a little bit of a robot, if you wish, but a lot less complex. So they are handheld instruments, but they still spin 270 degrees, and I thought that perhaps there could have been a good compromise to use the seals port, so it's single port access with instrument that could spread inside the chest cavity. So at the end of the day, you just need some retraction, so and then use it's a ligature of harmonic scalpel to dissect the tumor around, and it worked.
Yeah, sounds great. And how do you do your thymectomies?
So we actually in Maastricht, we are a referral center of thymectomies in Netherlands. So we do that with the robots from the right side. Most of the cases, I mean, in the special cases, if the thymoma is more on the left side, or we see it is easier from the left side, we do it from the left side. We use a CO2, and we it is actually very easy operation to do, and we do also thymomas also with the robot.
And when I did it from the right, I found it difficult to find the left phrenic, but you had a little trick for that, didn't you?
So yes, you can hyperventilate the lung, and then your phrenic valve will be visualized. So that is the trick.
Yeah.
And you have more space on the right side. But I think you are justified to go from the left side if you think that it's easier, and in some cases we do that. I think in 80% of the cases we go from the right side.
Yep. And how extensive a thymectomy do you have to do for these non-thymomatous myasthenics? There's bits of fat hidden under the innominate, there's bits up in the neck.
You have to clear the whole anterior mediastinum from every fat that you
so
see.
if there's fat there, you haven't done a complete one. Yeah.
Yes.
Yeah. So
I think that is the most important factor in that operation.
And even over the diaphragm and inferiorly.
Yeah, you go as low as possible, and then you take out everything you see.
Yeah. How long does that take you?
Yeah, I think about the whole operation about 2 or 3 hours, if you want to clear everything out.
Yeah.
But with the robot, you lose time with setting up the patient. So.
Yeah, you do. And do you get a biopsy for all your thymomas first, or
no,
you're not too bothered?
No. Only if we have any indication there is an invasiveness in the great vessels, then we convert.
Yeah, and I do love gadgets. I've seen a few other things. And I understand there's a new stapler for the robot. I've seen the new 5mm micro cutters. I don't know if you've had a little look at them. And then I suppose thinking about other gadgets, Maquet have got a new digital drain that is self-cleaning. Have you ever seen that? Or do you use digital suction devices?
I use a digital suction device, and again, but the drain that we use is the Medela Topaz. It still sense if there is an occlusion in the system, plus also sense the intrapleural pressure. It seems to work very well. Overall the nursing staff are extremely pleased, and so are the patients. Had a huge benefit from the adoption of this technology.
Yeah, and I suppose just to wind up, I suppose some people watching this video may be trainees sort of looking into training, and Payman, you are the trainee representative. I mean, what do you think is in the future for training for VATS Lobectomy? What new innovations do you think there might be?
I think the most of innovation that the trainee is going to benefit from is preoperative simulation and real physical simulation of operation. That you have to, as a trainee, to be trained sufficiently in basic technique of VATS, and then subsequently that you will have a creation of high fidelity simulators for each operation.
We have it already.
So
I've seen it in another meeting, and it's amazing. It was like a prototype, but it looks like you are into the chest. They had the full model for minimally invasive esophagectomy. It even bleeds if you do something wrong. And you have another version with haptic feedback as well. And now they are developing, I think it's pretty much ready now, a module for VATS lobectomies as well. But it's absolutely amazing.
Great. Well, it sounds like the future's that all the trainees can just sit at home and practice it and go straight into consultant practice. So that's we won't have to train them in real patients. Isn't that fantastic? Well, I think we'll leave it there on that very positive note. And so to Marco and to Payman and from myself, Joel Dunning, thank you very much for coming and goodbye. Thank you for watching.